Derita, derita, derita. Stop, stop, stop. Okay, okay. Up, 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 up. Don't move. Asparagus.
Hey guys, welcome back to my channel. So in the video today, I'm going to be discussing my capstone rotation. So my capstone rotation, I made a video about this earlier, just discussing what I was going to do my capstone rotation in. And for those of you who haven't seen it, I did it in burn. So I did it in burn management. I did it at a well-known center here in Texas that sees a lot of patients that have burns. And so we saw a lot of burn patients. We saw a lot of Stevens-Johnson syndrome, your toxic epidermal necrolysis, so your TENS. We saw a lot of pemphigus vulgaris, so your really extreme skin reactions that are deadly. So that's where I did my capstone rotation. So real quick, what is a capstone rotation? Now, you know, PA programs across the nation, they're different in regards to the program length and then also what they have encompassed in their curriculum, right? So for my program, it's 2.5 years. It's 1 year didactic, 1 year clinical year, and then you get half of the year a rotation where you want to do that rotation that entire half of the year. So it's something that you want to do once you graduate from PA school. Some of my classmates did in family medicine, pediatrics, cardiology, gastroenterology, surgery, etc. I did mine in burn. And the reason why I did it in burn is because I'm from the city of San Antonio. When I used to work there in San Antonio, and a lot of hospitals throughout the city of San Antonio, most of our patients that we saw that had extreme skin reaction, we would transfer them to these facilities, or this facility specifically. And I was very interested in that facility because it's very well known for just, you know, the patients that they accept, the fact that it's like level 1, etc. So the fact that they were with my program and I was able to do my rotation with them, I was like, yes, I want to do this. And I like critical medicine, critical care. I like emergency medicine, hospital medicine. I like anything that's like critical care. And that's why I decided to do this rotation. Also, I just find that very interesting, your acute care, critical care medicine, emergency medicine. So that's why I decided to do my rotation in the burn unit. And I have to say that I loved this rotation. It definitely was my favorite rotation out of all my rotations that I've had. So I would say my top rotations was definitely my burn care rotation, and then my nephrology rotation was also one of my top ones. But my burn one was definitely my favorite rotation. I do have to say though that it was definitely a hard rotation. It's not by any chance an easy rotation. It's a very hard rotation. Just because, you know, in PA school, when you are learning during your didactic year, for us, I think we only had 1 day of burn, and it was just very broad. Teach you very broad on burn, and that was it. And here I'm gonna spend an entire half a semester, you know, in burn. It's a specialty, and that's why it was really hard for me, because it's a very high learning curve that you have to learn. Not only for you, but I also saw you as a PA student, but I rotated with other medical students, I rotated with residents, and we all struggled. We all struggled, but it was really interesting to see how much, you know, we had all grown and how much we had gotten better from day one when we started to when like I left the burn rotation, or for them whenever they were done with their rotation, because they would do a month rotation in the burn units versus me. I was there for like 3 months. I was there a little bit longer than your other medical students and your residents, but it would just, you would see how much improvement there was from day one. I do have to say I am not a master. I felt like I could have improved a lot more, but it was just a difficult rotation. Like I said, a very high learning curve as a student. But regardless, I'm very blessed and I'm very happy for everything that I gained during that rotation. But just let's start with how it was. So I went in, thankfully, Monday through Friday. I followed 2 PAs, and Monday through Friday I would go in. So we would go work from like 6 to 2. But I would get there around 5 a.m., 5 to 10 a.m. because I wanted to make sure that I started rounding on the patients and started getting their information, because at 7:30 is when we would round on all the patients. And that's another thing I liked about this rotations, is that they emphasize collaborative medicine, or collaboration between different specialties, okay, different type of individuals that treat patients. So I really liked that rotation because of that. We all work together. We work together as physicians. We work together as the nurse practitioners, PAs. We work together as the nurses. We also had physical therapists, occupational therapists that we work with. And we also had social work that we work with. Everyone worked together to make sure that we were taking care of these patients. And that was something that I really liked about this rotation, and something that I did not see in my previous rotations. So we would start running at 7:30, and so I got there around 5 a.m., right? What I would do once I got there at 5 a.m. is I would log onto my computer. They gave me log access. I would log into my computer and see all the patients that we had. So I would go through every single patient, look at their history. You know, if it was a patient that we had from the previous day, like I came in on a Tuesday, and I was looking at the patient's chart from Monday, from that prior day. I would look at their labs. You know, are they anemic? How is their hemoglobin level? How is their white blood cell count? Because one of the things about burn patients is that since they have so much skin that's exposed, they're very prone to getting, you know, your bacterial infections like cellulitis, or even more invasive infections like, you know, shock, etc. Especially your SJS patients. So that was one of the things that I would do. I would go in and look at their labs. I would look at their white blood cell count, look at their hemoglobin, look at their potassium level. Are they hypokalemic? Sodium, do we need to replete their magnesium? Is it low? Is their phosphorus low, etc.? And then I would also look and see how much your input and output you would do. So basically what you would do in your hospital medicine, right? You go and you check through all the patients. Did anyone see them overnight? For example, I consulted the previous day cardiology because I was trying to control their hypertension, but it's not being controlled by the hypertensive medications that I'm giving them. Do they have a suggestion for a better medication for hypertension so you can do consult with them? Or like patients that had like SJS and had acute renal failure, nephrologists, they went yesterday with dialysis with nephrology. How much, you know, did they get off? How many liters did they get off? So that's why you review these patients every day. And then of course, you would also see these patients before you start rounding. So that's why I would get there so early, because I was so slow at reviewing everything. And I'm which is not good, and I'm really trying to work on that. I'm very particular about numbers. So I wanted their blood pressure to be between 120 and 80, right? Anything that was like off or low, I was like freaking out. And so I always wanted, like, if it was like high, I wanted to bring it down, etc. But you know, sometimes it's permissive in these patients. If they're burn patients, sometimes it's permissive because they have such a large burn burden. But of course, with really high numbers, like greater than 180 systolic, and that's something you want to look into. But I mean, something that's mildly elevated, you can possibly observe that, but I didn't know that. And I was very focused on the numbers, like your systolic blood pressure, diastolic blood pressure. So I always freaked out about that, and that's why it took me forever going through these patients. Of course, I got a lot faster by the time I got towards the end of my rotation, but that's why I would get there at 5 a.m. because I wanted to make sure that I was done going through all the patients that I had, even though honestly I didn't have that many patients. I probably had like 5 or 4 patients. Max, I think I had 6, but I had like 5 or 4 patients that I would see. But since I was so slow going through everything and just like learning the system and maneuvering through the system that the hospital uses, it took me a while. And I was very stressed because I wanted to make sure I was done by 7, because by 7, that's when I start rounding on my patients. So at 7, I would start rounding on my patients. The good thing about the burn unit where I went is that they're very hands-off. So they'll let you do as much as you want. And really, learning is up to you. Like, do you want to take that step to learn? Do you want to take that initiative to see patients? Do you want to take that extra initiative, taking that extra patient? Like say you have 5, you want to take that extra 6th patient. Do you want to do that initiative to do this procedure on this patient? It's all about initiative. And of course, you know, everyone's going to notice if you're wanting to take that initiative. Other nurses, the burn surgeons, and they're all about you learning. So that's what I really liked about that hospital, is that they were all about you learning and you taking that initiative. If they see that, then they will definitely teach you as much as you want to learn. And that's how it should be with your other rotations. You want to make sure that you're always taking that initiative. Don't wait for the doctor to ask you. Of course, ask for the permission. Hey, can I go see this patient? Hey, can I do this? But if you're not taking initiative, you won't get out of your rotations what you need to get out.
Another one.
And so that's what I definitely learned in this rotation of my burn unit. So at 7, I would go and see my patient at 7 a.m. and I would go and see them. So if it's a patient that's a burn patient, what we would do is that we would place them down for rounds. So what it means is that we would uncover the wound area so that we can look at the wound area, see how the wound is healing, is there any underlying cellulitis in that wound, any underlying infections, because like what we care about these patients is cellulitis. Your fungal infections can be very deadly for these patients, especially if they become systemic. So we always want to make sure that we look at those wounds. We also have patients with ulcers. Especially I had a patient that had Guillain-Barré syndrome. So she had like a sacral ulcer, right? Because this patient cannot move. And so we're having to move her positions to make sure that she doesn't have her sacral ulcer even worse. So we would look at that ulcer and see how is it progressing? Is it getting better? Is it getting worse, etc. So when we made these patients down for rounds, including your sacral ulcers, your burns, SJS, is when they would be down for us to look at the wounds. And of course, our nurses, which are just magnificent, they would put the patients down for rounds. So they would remove all of the wound care that they had, so we would look at them. So when they were down for rounds, regardless if they were down or not, I would go and see them. So then usually they had like a plastic film, you would kind of say. So I would kind of take that off, peel it off, and then I would just touch the wound. And I would touch throughout the wound, especially if it's a new patient that's coming in with a burn. You want to see whether it is a second-degree burn or third-degree burn. Now, at the hospital we're at, we definitely don't use those terms anymore, right? Now it's kind of more of your partial thickness burn, your deep partial thickness burn, your full thickness burn, etc. So I would look at the wound and feel it, Is the patient able to feel pressure? Yes. Or is it causing pain whenever I touch on it? No. So you would think maybe about your deep partial, wounds. And of course, anything that's full thickness, usually that's when you see like muscle and like bone and stuff like that. And so I would go and look at these patients and then just look at the wound, especially your new patients, to see, is it full, partial, deep partial, etc. We didn't see any superficial patients in our burn department. It's usually deep partial thickness, and then your full thickness burns. So I would go and see these patients, and then depending on my assessment, I would go and see them and then write on my notes, you know what, I think this patient has like deep partial thickness. I think they would benefit possibly from this type of cream. I mean, there's so many creams that I learned about that they didn't teach you in PA school. Specific creams, like a bunch of other creams. And then also wound care. What is your wound care for this patient? Does this patient need to go to surgery? Like, is a burn on an area that can cause a contracture? What's a contracture? Is that whenever you have a burn in an area, for example, say you have a burn in your hand, right? And say it's over like your knuckles. And if the patient does not get treated or get surgery, when it starts healing, it's going to cause a contracture. So it'll start scarring down, right? And it's going to limit that rotation or that range of movement of these patients. And that's why it's really important that in patients that have like deep partial thickness burns or even full thickness burns in areas that are areas of mobility, that these patients go to surgery. And also, once they get out from surgery, this is when physical therapy and occupational therapy works with the patient. And why they're so vital to the burn team is that they work with these patients and they help them, start increasing their range of motion, slowly and progressing. That way they don't develop a contracture. And so whenever I saw these patients, that was something that I would take into consideration, working with physical therapy. Do they need to go to surgery? Can they be discharged that same day? Sometimes we would get patients that would come in just to rule out Stevens-Johnson syndromes or your 10 and we would look at him, and sometimes it was possibly just a viral syndrome that they had that caused this rash, and we can possibly discharge these patients. Of course, I would not discharge a patient that's like older and they have all these other significant comorbidities, possibly observing from another day, just to make sure that they're not developing SJS or TENS, because the thing about SJS and TENS is that it can present later. It doesn't usually present, sometimes it does, but it doesn't present acutely. And so, yeah, that's what I would do. I would go and look at my patients and round on them on all the patients that I had. And I had a variety. I would have SJS, TENS. I had a patient that had chronic venous stasis or stasis dermatitis, and they thought it was burn. So they actually transferred it to us, ended up not being a burn patient. And so, I mean, you would get a different types of patient. I had a patient that had like TENS, very, very sick patient, ended up passing away, unfortunately. But I would round on all my patients, and then once I saw them, I would develop a management plan for these patients. And then once rounds came, which was at 7:30, everyone would come. So it would be the nurses. Well, usually it would be the charge nurse, and then sometimes the nurse that was in charge of that patient would also join us during the round. And then it would also be your physical therapist, your occupational therapist that would come, your burn surgeon that was like on call for that week. We also had our social workers that came in and worked with us also. We had our wound care team that came in. And then we also had psychiatry, because most of these patients do have like PTSD, especially if they were involved in like burn and a huge burn that occurred at their home. And if they had like significant others that died, definitely we had a lot of depression with these patients, of course, anxiety. So we had psychiatry with us also. So we would all come into a group, and this was one of the things I always got nervous about, was presenting my patient, because I feel like I'm talking in public, and I feel like I get really nervous in public. So we would go and stand in front of the patient's door, of course, with the doors closed for patient privacy. And then I would go and present the patient. I have a 49-year-old female that has a percentage of burn, right? And that's another thing that we saw. So whenever we had a patient that came in and was a new patient that came in with a burn, we had to go in there and use a lung browser chart, right? And then also calculate how much percentage or total body surface area was burned, and how much of that was not superficial, right? Because we do not consider superficial as a burn. It's anything more than that. And then, is it full thickness, partial thickness? Is it mixed? So then I would present 49-year-old female with 9% TBSA. And what type of burn is it? Is it a thermal burn? Is it an electrical burn? Because we saw patients with electrical burns also. Those are very scary, because these patients can develop compartment syndrome. So sometimes they have to go in there, do fasciotomies, right, where you open that muscle up to make sure that they don't have increased pressure that can cause that area to be necrotic. So we would get, whether it was a thermal burn, electrical burn, was it a grease burn, different types of burns. So you gotta make sure that you describe it. I have 49-year-old female with 26% TBSA thermal burn, and presenting with, and then what type of burn is it? Partial thickness, deep partial thickness, full thickness burn, etc., right? And then you start saying that, and then of course another thing that they wanted to know is, when did the burn occur? So it occurred on January 2nd, 2020. What was the patient doing that caused a burn? So you can say the patient was frying fries and they burned themselves. They accidentally dropped the pan on their arm and it burned them. Or the patient was involved in a house fire. Or the other one, the patient was, like, we had a lot of patients that worked as electricians. The patient was working, etc. So you needed to describe the date and the mechanism of action. Once you did that, then that's when you go and you do the body systems. And that's one thing I really liked about this rotation, is that it really teaches you on how to present a patient and how to present the patient well. Like, what information is vital? What information do you need to present in your presentation? And what information do you not need to present? What does the surgeon want to know? Surgeon usually wants to know, do I need to take them to surgery or not? That's usually what they want to know. Or is there anything acute that happened with this patient overnight that I need to know? So you would go into that, of course. And then once you're done with that, you would discuss if there was any events that happened in the past 24 hours. For example, my Guillain-Barré syndrome patient, she was coming in because she actually developed necrotizing fasciitis to her forearm area. She was an IV drug abuser, and she got Guillain-Barré syndrome also secondary to that. So they had to go in there and remove all the tissue. But she would become hypotensive so many times on us, and they needed to call usually a code on her because she'd become hypotensive. Sometimes she would be tachycardic, etc. So that would occur in the past 24 hours. And I would say, you know what, Miss Hernandez had, this occurred over the 24 hours. Okay, what did you do? What did you do? They did this and this, but when I came in the morning, I wanted to make sure I check her cardiac enzymes just to rule out that she's not having a myocardial infarction because she doesn't have a history of coronary artery disease. And we did an echo on this day, etc., etc., etc. So anything that happens in 24 hours. And then after that, we go into my vital signs. If it's vital signs are normal, patient is hemodynamically stable. That was something I would say. If patient is not stable, I would say patient is tachycardic, 137, but we're currently giving her like a atenolol or metoprolol, X amount of milligrams for the tachycardia. And so you would discuss that. Once you've gone into your vital signs, and that's when you go in your systems, right? Usually I would go and proceed to since our specialty is wounds, I would then proceed into the wounds. So how are the wounds looking today? So when I looked at it, the wound today located on the X area, for example, on the forearm, on the distal forearm, etc. Patient was sensate to touch and pressure, but was not sensate to etc., etc. Patient has decreased range of motion. The wound has cellulitis or has some like erythema that has not improved in comparison to the previous day. And then you tell them, well, what do you want to do about it? If you think it's cellulitis, I would like to start the patient on vancomycin, right? Oral vancomycin for the cellulitis and see how the patient is improving tomorrow. If she's improving, we can probably discharge her home, send her home on doxycycline, etc. So you always tell them how the wound looks. If the patient needs to go to surgery, then you can tell them, you know what? The wound, for example, is circumferential, so the burn is circumferential. It's covering the entire thigh, and I am worried that it might compromise blood flow. So I feel that she would benefit from going to surgery for a graft. So the surgeries that we did were also grafts, etc. And so you would also describe your plan. Once you're done with your wounds, that's when you start going down. So you go top to bottom, right? For example, cardiovascular, right? If there's a patient that has anything with ENT, I had an electrician, for example, that had an electrical injury, so that patient also had a concurrent subdural hematoma, and so they were complaining of vertigo symptoms. So that was something you can possibly also discuss in ENT. And then pulmonary, for example, I had a lot of patients that have COPD, where they have an acute attack of a COPD exacerbation, etc. And then GI, and that's how you would work down. And then of course at the end, once you're done, the doctor or the burn surgeon that was on call, they would say, you know what, no, I don't agree with your plan, or I agree, but I would add this, this, and this. Or for example, I don't think that they would benefit from surgery because of X, Y, and Z, or I think that they should go to surgery just because of where the burn is located, and etc. So that was one of the things I really liked about this rotation, because it teaches you. They were very prone to teaching, and so that's what I really liked about this rotation. Also, wound care management. I think you should do this for wound care management. I think you should apply this cream or this solution instead. Or this patient should get a wound vac, or I think they would benefit from a wound vac. And everyone put their input. Also, we had our wound care management nurse that would, their fantastic nurse, fantastic. He would put in his input in regards to wound care, what he would suggest. Also physical therapy, they would update you on the patient, how's the patient doing? Are they going to physical therapy? Physical therapy has to go with them, of course, but are they actually trying with physical therapy? Are they actively moving, or do they just don't want to move at all? And so they would also give their input. Psychiatry would also tell you whether they had been following up with the patient, what recommendations they give to you for what medications you should add. This patient's having trouble sleeping at night, they have PTSD, etc. Maybe possibly try something like trazodone, or this patient is just not eating, especially with your patients that have SJS, since they have this mucosal involvement also, it's very painful for them to eat. So you can possibly add a medication like mirtazapine that's increase their appetite, etc. And so I really like the fact that they give you their input. And then of course as students, you're wrong, and that's how you're learning. So I really like that about this rotation also. So that we would do that for every single patient. Once I was done writing with my patients, I would go back to my computer, and then rounds usually lasted about an hour. And then the rest of the day, of course, we would spend writing our notes. And that's another thing that I liked, is that they're very hands-on. So I learned how to write a detailed note for an inpatient hospital and how to write it according to system. So you would start with your general, right? Your description of the patient, and then also any significant past medical history, etc. So it was very, very particular, very specific. You would go into discussing your organs, what are you doing for each one, if they have hypertension. I'm putting them on lisinopril, etc., the medication and the dose. And then at the end you would put, for example, this is what I'm going to do with this patient. I'm going to transfer the patient to this place, for example, if they need to be transferred. If it's not a patient that has SJS, or like a patient that I had that chronic, had a venous stasis and was not a burn. So in these patients, you would transfer them, right? And then do you need to consult dermatology? Is it a new case of Stevens-Johnson syndrome? Usually for all our patients that have SJS and TENS, we require a biopsy to get a specific diagnosis. So do we need to consult dermatology? Do we need to consult cardiology, for example? Also, like, we've been treating this patient on these medications and the patient is just not responsive. So do we need to do this, and that for these patients? And so that was another thing that I really liked about this rotation, is that you really learn on how to do consults and when to do consults and not to over consult also for your patients. So we write these notes, and then the rest of the day, I really wanted to learn wound care management. So I would go and follow the nurses for wound care. I would go and follow them and learned a lot from the nurses, the LVNs, the registered nurses, technicians. I learned a lot in regards to wound care, hands-on wound care, how to apply the wound care, and the different types of solutions, lotions that we use, why we choose this over this, why is this more effective than this, when is it effective to apply wound back, etc. So that was another thing that I really, really enjoyed about this rotation, is that you really got to work with everyone. I got to learn a lot about social work, how important they are to the patient, physical therapy and occupational therapy, how important they are. I was able to spend 3 days with occupational and physical therapy and learn about the role in burn patients. And they have a huge role in burn patients in regards to making casts or splints. Like, how are they going to make the splint or the cast? Are they going to place it in dorsiflexion, plantar flexion, etc. So I learned a lot about them. Also, which cast do they want to place, etc. So I learned a lot about physical therapy, occupational therapy. So that was something that I really, really liked about this rotation also. Loved it, loved it, loved it. So in general, this was definitely one of my favorite rotations. Like I said, I struggled a lot because I think it's one of my weaknesses that I have to work on now, is the fact that I get all this information, but I'm not able to put it together. And that's how it should be. You get all this information. Okay, this patient's hypotensive. They're tachycardic. Their white blood cell count is high. Their hemoglobin is low. Like, that should give you a picture for sepsis, right? And so that's one of the things that I need to learn, is how to put all the information together and how to deduct from all this information, is doing that. And that's one of the things I struggled with. And finally, I think like the last few days is when I started getting a little bit better. And also how to be confident and how to treat patients. That was one of the things I was not good at, is I was not confident.
So I remember that whenever I had a patient and I'm done with my presentation, right? So I'm rounding with the physicians and the surgeons and I'm done with their presentation. And then I would say, you know what, I want to do this for the patient. And then I would look at the doctor, and the doctor would look at me, just wait for me to finish. And then in my mind, I'm like, so is it a yes? Is it a no? And something, they gave me feedback on is that I would always say, I would like to. No, you're going to say, I'm going to, or I will, not I would like to. So I would say, I would like to add this diabetic medication because this patient's blood glucose has been increased the past 2 days, or I want to increase their insulin from a medium to a high dose sliding scale insulin, etc. So I was very nervous and I was not confident in myself. Thankfully, during that rotation, I also wanted to thank one of my fellow classmates that rotated with me. We both stuck together, and I think we both survived because of that. So I'm really thankful to him. He was a fantastic student. I know he's going to be a fantastic physician assistant also in the future. But yes, that was my rotation. Another thing that I really liked about that rotation is that like I said, they're all about education. So they always offered a class from 12 to 1 in regards to a topic in burn. So whether it was just a pathophysiology of burn, the physiology of the skin, how to manage sepsis in burn patients, how to grade burns, how to use a lung Browder chart, etc. They always had a topic every day, and you had different staff members teaching it, whether it's a nutritionist. That's another individual that we also had during our rounds was nutritionist. It's really important, the nutrition for burn patients, to make sure that they're getting the appropriate nutrition, because nutrition is going to help them heal their wounds. If they don't have the appropriate nutrition, if they're not eating, then they're not going to heal their wounds. I remember I got scolded by a nutritionist, which in all fairness, I deserved that scolding. Is that there was a patient that came in, I think more than 30% of her body was burned, and she was on feeding tubes. And I wanted to take her off feeding tubes, and she was not healed. And that was a big no-no. And I got chewed out by a nutritionist, which I totally deserve that, because I was just not thinking. And so what I learned from that is that obviously with these patients that have large burn wounds, if they're not increasing their diet, that's another thing that we would check, is to see how much oral intake do they have. If they don't have a good oral intake, we have to maintain them on tube feeds until they can start increasing that oral intake. Then we can take off their oral feeding. So all patients, if not the majority of them, don't like having something up their nose, feeding them. They prefer to eat, but sometimes they can't because of just their burn wound. Or for example, if they have SJS or TENS that involves like their oral mucosa, they have problems swallowing. And so that was something that I definitely learned. So some nutritionists would also give lectures on the importance of nutrition for burn patients. So I really like that about this rotation also, is that I always made sure I went to the lectures every day. So yeah, that was basically my experience in the burn unit. I really enjoyed that rotation. I learned a lot, as you can tell. I learned a lot about, all the other individuals that form part of our healthcare team. Sometimes we take them for granted. Sometimes we don't know about what their role is. And I definitely learned what their role was in regards to the care for the burn patient. I really enjoyed my time with the physical and occupational therapists. I do not know, I would say, half of the information, or less than half of the information that they know. They're very good with their nerves. They're very good with their muscle locations. Their anatomy and physiology, they're amazing. And I'm for sure that's one of my weaknesses. And so I know when I was with them those 3 days, I was not good at answering any of the questions in regards to, what is innervated by this muscle. No. But I learned a lot about them. The nurses, the burn nurses, the LVNs. I had LVNs that I wish I had their knowledge, 20 years of burn experience, just amazing on burn care wounds. They would also give me advice. You know what? I think you should do this for this patient. Of course, I'm going to take their advice. They know more than I do. So yes, I love this rotation. Highly recommend it for those of you, if there's a burn center in your area, maybe do it as an elective rotation. For those of you who are interested in emergency medicine, critical care medicine, hospital medicine, because we were not only treating burn management, but we were also treating all the other comorbidities that these patients present with, or with all the complications that these patients can present with also. Some patients would get fungal infections, we had patients that would come in with like chronic renal failure, congestive heart failure, and of course with these patients you can't take them to surgery, so you have to manage them non-operatively because they have very high risk comorbidities. And so that was another thing that I learned about this rotation. Loved it, loved it, loved it. Hopefully this video was helpful for you guys. As always, if you guys have any comments or suggestions, please comment below, and I will talk to you guys soon as I can. Bye.